am tasked to discuss on metabolic disorders screened by NBS. This is the outline of my presentation, and these are the following objectives. IEM are a group of disorders that may be inherited. Majority of the inborn errors of metabolism are inherited in an autosomal recessive manner, or they may occur as a result of spontaneous mutation. Although any given IEM is very rare, taken as a group, it occurs in 1 in 1,500 births, making them quite common. They can present at any age. The term was coined by Sir Archibald Garrod in the year 1902 when he discovered the first metabolic disorder, alkaptonuria. It attracted his attention because an infant stained his clothing or the urine has a peculiar appearance which was black. This led to his hypothesis that there are point defects in the metabolism which cause such disorders. This is the principle of Garrod's hypothesis. If there is a block in the metabolic pathway, this will lead to an increase in the substrate proximal to the block, which will cause production of toxic metabolites and deficiency of the product. IEM involve failure of metabolic pathways in either the breakdown or storage of carbohydrates, your fatty acids, and proteins that are basically for energy production. These can be divided into the following 3 diagnostically useful groups. Group 1, disorders which give rise to intoxication due to defects in the intermediary metabolic pathway, resulting to accumulation of toxic compounds. Most are treatable. Example are your urea cycle defects and amino acid disorders which are being screened in our expanded newborn screening. Group 2 are disorders involving energy metabolism due to deficiency in energy production or utilization within your liver, heart, muscle, brain, or other tissues. Example are your mitochondrial disorders, glycogen disorders like your Pompe disease being screened in other countries, fatty acid oxidation disorders screened by our expanded newborn screening. And lastly, Group 3 disorders involving complex molecules, organelles like your lysosomes, peroxisomes, Golgi apparatus, endoplasmic reticulum way back in your biology. They are often permanent, progressive, and unrelated to food intake. Example are your lysosomal storage disease, which is available in the NBS panel of Taiwan. When to consider IEM? A metabolic disorder should be considered along with other diagnoses like your CNS infection, your sepsis, in all neonates with unexplained, overwhelming, or progressive disease. And particularly after normal pregnancy and birth, in all children with acute deterioration of the general condition or reduced consciousness, particularly when preceded by vomiting, fever, or fasting, and in all children with symptoms and signs of acidosis or hypoglycemia. We need to have a high index of suspicion. So as we have said a while ago, a normal infant at birth, usually term, who presented with illness within the first 48 hours of age. We also ask for the history. With the family history of neonatal death of unclear etiology, history of child with neurologic deterioration, history of multiple miscarriages, consanguinity, and taking into consideration the clinical presentation of the patient, like poor oral intake or vomiting, lethargy, coma, seizures, change in tone or reflex, hepatosplenomegaly and dysmorphic features, and also cataracts. And if IEM is a consideration, we have routine laboratory investigations that may provide clues for an IEM. You always need to check the NBS results. And if there are also secondary investigations requiring the help of metabolic specialists, and if we opt to order these metabolic tests, one should know the utility and implications of these tests. So these are the 6 disorders screened by the traditional NBS and the expanded newborn screening. We have already 28 disorders, specific disorders of carbohydrate metabolism, your protein metabolism, and lastly, fatty acid oxidation disorders. I will be selecting some disorders and presenting a case of a 7-day-old term, 37 weeks, with a birth weight of 2.3 kilograms on breastfeeding, who came in due to vomiting. Patient was temporarily placed on NPO with noted improvement. However, on reintroduction of lactose-containing milk, there was recurrence of vomiting. So question, what metabolic disorder that is being screened in the newborn screening can also be considered aside from sepsis or infection? So we have galactosemia. It is an inborn error of carbohydrate metabolism characterized by elevated levels of galactose and its metabolites due to enzyme deficiencies. Galactose is the sugar found mainly in milk and dairy products. It is also produced by the body. This is the endogenous galactose. Milk contains a sugar called lactose, and during digestion, this is broken down into sugars glucose and galactose. Glucose can immediately be used as a source of energy, but galactose needs to be further broken down. There are 3 different enzyme problems that can lead to galactosemia. The enzyme that is reduced or missing is called GALT, galactose 1-phosphate uridinase. This enables the body to break down galactose into glucose. And next is your GAL, or your deficiency in uridine diphosphate galactose 4 epimerase. It is the severe type, clinically resembling classic galactosemia. And the third type is GALK, or your galactokinase. They present primarily as cataracts in untreated patients. Clinical manifestations, they present with feeding problems like vomiting or diarrhea, usually begins within a few days of milk ingestion. Failure to thrive is the most common initial clinical symptom of classic galactosemia. Hepatocellular damage, bleeding, and sepsis are also seen in untreated infants. There appears to be a high frequency of neonatal death due to E. coli sepsis. In approximately 10%, cataracts are present, and these have been observed within a few days of birth. It also causes learning and language problems, bone mineral density problems, and ovarian failure in girls. Management includes dietary elimination of milk and milk products containing lactose, because there is no chemical or drug substitute for the missing enzyme at this time. An infant diagnosed with galactosemia will have to be on a soy-based formula. Regular monitoring of blood galactose levels and regular evaluation of the patient is very important for optimal treatment. This is a case of CM, a 5-month-old male, full term, born to a G4P3 3003 mother by a normal spontaneous delivery at a lying-in clinic. The expanded newborn screening result showed elevated phenylalanine levels. But the question is, what is the most important and sometimes the only manifestation of this disorder? What is this disorder? It is PKU, or phenylketonuria. It is a disorder of the aromatic amino acid metabolism in which phenylalanine cannot be converted to tyrosine due to a deficiency or absence of the enzyme phenylalanine hydroxylase. This PAH requires a cofactor, your tetrahydrobiopterin, or BH4, for the activity in the hydroxylation of tyrosine. So absence of this cofactor may also present with increase in phenylalanine similar to PKU. The clinical manifestations of PKU, they appear normal at birth, and the most important and sometimes the only manifestation is mental retardation. The intellectual developmental disorder wherein IQ is less than or equals 50. Patients may present with intellectual, neurological abnormalities, and also signs of hypopigmentation of the skin and hair and iris. Eczema is seen in 20 to 40% of patients. The odor of the phenylketonuria patient is that of phenylacetic acid, described as mousy, barny, or musty. Dietary management is the key to treatment, and there should be complete avoidance of food containing high amounts of phenylalanine, your aspartame, which is an artificial sweetener. All food containing aspartame should be avoided, and there should be calculated intake of low protein and phenylalanine natural food. This is the case of KH, an 8-day-old, born term, 40 weeks, age of gestation, via normal spontaneous delivery to a gravida 1 para0 mother with no fetal-maternal complications, discharged well after 24 hours of life. However, on admission, there was noted cycling movements of extremities, like this one, boxing movements with fair activity, weak cry, and sweet smell, like burnt sugar. Initial NBS done on the second day of life rated leucine levels, and on admission, repeat leucine was very high, 4,800 that needs peritoneal dialysis. Here is a case of MSUT. This is due to a defect or deficiency of your BCKD, and this will cause elevation of your branch chain amino acids, your isoleucine, leucine, and valine. Clinical manifestations, again, they appear normal at birth, and they have a poor shock, lethargy, with opistotonic posturing, with seizures and coma developing on the 4th to 7th days of life, with characteristic odor of maple syrup. Management includes dietary restriction of protein, supplement also with valine and isoleucine, because it will have a competitive inhibition with leucine, and also frequent determination of leucine levels, because leucine is the most neurotoxic of the 3 branch chain amino acids. This is the case of CI. Patient was born term with no complications. NBS done on the first day of life showed positive Tyre 1. SA here is succinyl acetone, which is elevated. As per protocol and algorithm, repeat collections were done, however, still positive for Tyre 1 and succinyl acetone. On recall and evaluation, the patient seems asymptomatic. However, on further laboratory workups, there was deranged coagulation studies and significantly elevated alpha fetoprotein. That should be AFP. And so she is the first tyrosinemia type 1 patient upon the implementation of our expanded newborn screening out of the 7 Tyre 1 cases in the Philippines. So Tyre 1 is also known as Hepatorenal Thyrosinemia. This is due to a deficiency of the enzyme FAH. You can see here the yellow drug, which is the NTBC or nitisinone, because it will block your tyrosine degradation at an early step to prevent the formation of these toxic metabolites, your FAA, this one, your MAA, and your succinyl acetone. They are usually asymptomatic in newborns, but if left untreated, it affects liver, the kidney, bone, and peripheral nerves. There can be acute hepatic decompensation where infants are noted to have jaundice, abdominal distension, failure to thrive, ascites, and hepatomegaly. Renal disease is also prominent, and the boiled cabbage odor in urine is observed. Chronic liver disease feature is that of hepatic cirrhosis. So what is the management? Of course, restriction of your phenylalanine and tyrosine. Again, your nitisinone or your NTBC. And for long-term management, liver transplantation. Next, a 1-year-old came in with a chief complaint of seizure. CT scan showed subdural hemorrhage. Question, it can be an abuse and it can be a metabolic disorder, but we need to have a thorough physical examination and history for these patients. One of the metabolic disorders that can present with subdural hematoma and can be a differential diagnosis for shaken baby syndrome is glutaric aciduria type 1. This was first described by Goodman and colleagues in 1975. It is caused by deficiency of glutaryl-CoA dehydrogenase, which catalyzes the oxidative decarboxylation of glutaryl-CoA, which is intermediate in the degradation of these two amino acids, or lysine and tryptophan. Clinical manifestations include hypotonia with head lag, feeding difficulties, and irritability, and usually there is macrocephaly seen in about 75% of patients, but this is non-specific. If left untreated, 90% of patients develop neurological disease presenting as dystonic, dyskinetic posturing, athetoid movements, spasticity, posturing, rigidity, clenched fists, and tongue thrust, profuse sweating. So there can be subdural and retinal hemorrhages as what was earlier seen, and as I have said a while ago, this can be a differential diagnosis for shaken baby syndrome. Management includes protein intake restriction and tryptophan lysine restriction. So for our GA patients, we need to check on the labels of your multivitamins, prevent encephalopathic crisis and neurological deterioration. Carnitine will help in the reduction of your toxic compounds, and neuropharmacologic drugs to control neurologic symptoms. So lastly, for the last case, a review of your energy production. So your carbohydrates are the main source of energy for the body. However, if there is depletion, such in cases of fasting, starvation, during sleep, the source of our energy is our fats. And one of the most common, this is the most common defect of fatty acid oxidation, and it results in a lack of production of energy from beta oxidation of medium chain fatty acids. This is your medium chain acyl-CoA dehydrogenase deficiency, or MCAD. Your fatty acids are made up of carbon atoms. They are joined together to form chains of different lengths. So we have short chain, medium chain, long chain fatty acids. And this table only shows you the food sources for these fatty acids. So what are the clinical manifestations? They may have hypoglycemia, coma and death, cardiomyopathy, weakness, hypotonia, and arrhythmia. And for infants, we they can present as SIDS. And the management is just avoidance of prolonged fasting. We can also give extra carbohydrates during nighttime or illness, like uncooked starch or pasta. And for the mothers, we advise them to continue breastfeeding every 2 to 3 hours and to avoid fasting for more than 4 hours for neonates. So in summary, IEM are rare, presenting with non-specific symptoms. Majority are autosomal recessive and most IEM are treatable. Early recognition and prompt treatment will lead to reduced mortality and morbidity, and with the help of expanded screening, diagnosis is already achieved, as well as counseling is very important for long-term management. Thank you for listening.